Hello, good morning from Madrid. I'm Alfonso Jurado from La Paz University Hospital. Beside me is Dr. Galeote, Ana, Pilar, and outside Borja, Virginia, and all the team. We have had some technical problems, but we have fixed them a little bit, and we are going to present our first case. Regretfully, we don't have slides, but Borja Rivero, one of our fellows, is going to explain you the case we have. Borja, please.
Good morning, everyone. Today, first case is a 58 years old male. As a personal history, he has hypertension and he is a former smoker. The patient went to the emergency room due to the typical chest pain lasting 30 minutes. In the analysis, an elevation of troponin was observed. The electrocardiogram and echocardiogram were normal. A first catheterization was performed in which the right coronary artery presents a proximal occlusion. A pilot 50 guide wire was advanced, the artery was predilated, and a stent was implanted with good result. Regarding the left system, he presents a severe lesion in the LAD ostium with doubtful involvement of the left main coronary artery. The patient was included in the IVUS-CHIP trial. The IVUS-CHIP is an international randomized controlled trial. Randomized participant with complex coronary lesion, severe angiographic calcification, ostial lesion, tube bifurcation, coronary lesion, left main coronary lesion, chronic occlusion, in restenosis, long lesions, Perfect. Or who require elective PCI. Assist by mechanical circulatory support to receive IVUS or angiography guide PCI. For this reason, the patient will undergo left main and LAD angioplasty assessed to the left main by IVUS.
Okay, so thank you, Borja. I don't know if we can show the angios of today in the screen.
Okay.
Okay, so the setting is that we have a radial access 7-in-6 slender sheath, an EVU-7 French, and two wires that has been crossed by Guillermo towards the LAD and the circ. The angios of today, because we cannot show you the previous one of the other day, are these. This is the caudal view. As you can see, there is a narrowing from the distal left main towards the LAD. The circ looks healthy, and the LAD is diffusely diseased. Probably difficult point is to decide where is the distal landing zone here, and this is the angios. These are the angios of today. And Borja, if the cameras can focus on the screen of the IVUS, we can share our findings. Please, okay. It's not the best option. If we can zoom it a little bit. Okay. So Borja, if you can put the run from the distal part.
Okay.
From the distal part to the ostium. Play. Okay, you are going to see the pullback from the LAD. You are seeing a diffusely diseased vessel. The distal zone is quite distal to the second diagonal. It's 2.5. There are some healthy segments, but it's difficult to choose the perfect landing zone. We have been discussing this issue before the connection. Some calcified plaques, nearly 180 degrees of the circumference. This is the diagonal, the second diagonal, rising. This is the proximal mid-LAD. Proximal LAD is 3.25, 3.5. This is the ostial LAD, and you're going to see the circ arising from the right of the screen. This is the circ with the wire, and this is the left main. It is quite big, 4 and something. Okay, Borja, can you show the bookmarks, please? This is the left main. This is the left main. Probably the vessel is 4 point something. Show the B4, B3, the bookmarks, Borja.
Es que no lo oigo. Espera, ¿qué dice? Es que no te oigo.
Click a los bookmarks. Okay, this is the proximal LAD, 3 point something, 3.5 probably. The next one, Borja. Mid LAD, and distal to this point probably is 2.5, all the vessel. Okay, yeah. So we can put the screens, okay? And now Guillermo can tell you our plan. Guillermo. No. Venga,
No,
Guillermo.
está bien. No, well, okay. I think that the principal lesion is the ostial LED. Probably we can the landing before the first diagonal is a good landing, and I think the rest of the LED is diffuse. And I think it's the principal problem is the osteon. I think I think that we have to treat this part,
Only this part,
this segment,
probably,
yes.
because if we treat everything, probably we are going to jail these two big diagonals, and the areas, the minimal lumen areas of these sites are not so diseased. Probably I have some doubts about immediately distal to the first diagonal.
Yes, but
Borja, can we see the IVUS between B3 and B4? Dale play.
distal to the first diagonal.
This is the mid part. This is the second diagonal. We know you are not seeing that, but we will explain later on. This is distal. Indeed, we cannot see the diagonal properly, probably because of the plaque. In my opinion, if you are seeing the angio, probably
I think we can implant it the stent in the
distal to the first diagonal.
First the
proximal part, and then see.
part, and then see, or even we can do
IVUS again.
pressure wire or
IVUS or whatever. Okay.
Whatever you want. No?
So we are going to predilate the osteon of the lady and the left main. Which balloon do you want?
Or cutting.
Or cutting, yeah.
Good.
The calcified plaque is not too heavy. Can you put the ostial LED, Borja? En nuestra estantería hay algunos Wolverine donde las oclusiones, Pilar. There. Okay, a little bit more distal. Okay, there. Okay. The plaque of the ostium of the LAD is not heavily calcified. Probably I am going to describe the image now. Borja, ¿puedes girar la pantalla aquí? Vente dentro. We're going to move the screen to focus with the cameras the IVUS to show you again como estaban antes, para que la pille esa cámara. I don't know if you can zoom the screen with the IVUS.
Probably it's a fibrotic plaque, no? Or
Yeah, it's a mixed plaque, probably there. Perfect. Not heavily calcified. We know from several trials that cutting or scoring balloons do not work well in heavily calcified lesions, but probably in fibrotic one or moderate calcified lesions is a good option.
Overall in ostial lesions.
In ostial lesions, but aorto-ostial probably has more elastic fibers. I don't know if ostial LAD lesions. So we are searching for some cutting balloons or NC balloons, and we will decide. Lo puedes poner bien, Borja. 3 and 5, Guillermo?
Okay.
3.5 to 10. Okay, we are using a Wolverine cutting balloon just to dilate the left main to the ostium of the LAD. Te pongo esto bien, ¿vale?
Thank you.
Okay, the patient is, as Borja said, on double antiplatelet treatment. After the primary PCI, the patient was admitted by an STEMI, but the right coronary artery was occluded. And the patient was also included in one study we are doing that is called IVUS-CHIP. Probably you know it. That is randomizing complex lesions to PCI IVUS-guided or not IVUS-guided using the Synergy stent. And the patient was randomized from the first procedure to the IVUS-guided arm.
2000 más de parina, ¿vale?
So we are advancing the cutting balloon.
Yeah.
Okay, we are almost there. Test, please. We are there. Probably a little bit more distal.
Yeah.
Okay.
More or less,
There. Which atmosphere do you want? 10? You know that the nominal is 6 and the blood rated burst is 12. I'm going to 10. There are some debate about down
Okay.
about the atmospheres you need to get with the cutting balloon. Sí. To be honest, we use them probably a similar way that a conventional NC balloon. Wait.
10, yes, please.
But we are being more conservative today with 10. Higher or 10 is okay?
10 is okay.
10 is okay. The expansion is quite good.
It's enough because the plaque is
It's modified, no?
Yes.
Do you want an NC balloon after that?
We can see the image.
We can do IVUS again, no? Okay. So we are retrieving the cutting balloon. Perfect.
Okay.
With IVUS to see the fractures.
On you. No, I think the reference the diameter is clear.
No, it's just to know if the modification.
I'm sure about the modification. Because
okay. Okay. I'm going to fill in the. Okay.
Yeah, I think this the. Vamos a hacer un cine si queréis.
Okay, the plaque has been changed a little bit. We can do a cranial view and see if we. Okay.
Okay, a ver.
Check, please. Okay, let's see here. Okay.
Dissection, no? So
a little bit dissected, yeah. I think the cutting balloon did its job. I am concerned about the plaque distal to the diagonal, but we can do, as Guillermo said, we can fix the proximal part with a stent and then recheck everything, no?
Yes. I think this probably we can implant it stent, no? 3.5 and 18 or 20.
From the left main to from B4 to B5 is 18 could be enough. You have a lot of left main length to land.
Okay. Please.
A synergy 3.5 by 18. Pilar, our nurse, is bilingual, so there is no problem. 3.5 by 18 synergy.
No sé si hay 18 o 20 incluso, ¿no?
O 20.
Es que en Synergy no sé. Sí, es
20, okay.
En Synergy no hay 18.
It's true. Okay. We're using a Synergy 3.5 by 20. If you are seeing the angio, we have probably in the left main 20 millimeters to land. There is a little bit diseased plaque in the proximal part, but I think we have a space to put 20 millimeters probably between this plaque of the ostium of the left main and proximal to the diagonal. Si ponemos la luz no se ve nada en la cámara.
Sí, 30 segundos.
No, sí, he visto que lo había puesto, pero está enfocando Ana. Ok, ¿tienes? Okay, we are advancing the Synergy stand. La que de la diagonal se ha salido un pelín, ¿no? De la CX, probably. Okay, this is the stand. Let's see.
Okay, before the first diagonal.
Test, please. Just there. You are there. Probably in the caudal view, we can choose the landing zone of the proximal one. Test, por favor. Puedo retirar un pelín.
I think the spider is
the spider is better.
I think so. Yes.
Mira, ¿verdad?
Test, please.
The proximal landing is okay, no? So the problem is the distal landing zone before the diagonal, no? Yes. A little bit more forward.
Vamos a hacer un cine y
Okay.
seguimos ahí, ¿vale?
Okay.
I think it's a good position, no?
Okay, let's go.
Yes.
I'm going to nominal, that is 11. Because it's a little bit, this is the distal plug part, 11. With expansion, okay, down. Blood pressure is okay. The ST a little bit modified, but just slightly, okay.
Wait a moment. Okay.
Okay, it's coming.
Test, please. O
Pero tienes
cine.
que tirar el este, ¿no?
No, así lo hago así bien. Vale, ok. No, vemos que la diagonal está por lo menos. Vale. Nitro, please. Luis, ¿qué tal? ¿Estás?
No te muevas de
No,
quieto,
Luis,
quieto, quieto.
Luis, no te muevas, por favor. ¿Qué tal? Bien, no te muevas las piernas que tenemos aquí todo montado, ¿vale?
¿Has puesto frente?
Sí, solo, bueno, un tercio.
Le ponemos todo tercio, porfa, Pilar. Si
Quizá con Nora un poquito.
La presión está bien, ¿eh? La curva es buena.
Vale. Un poquito de contraste, por favor. Now probably the lesion distal to the first diagonal is worse than before.
No, there was plaque there. Okay, let's do cine after nitro. Okay. Probably the plaque is similar than before, but you see the fixed proximal part. I think I told before, probably we need to fix it. We can do IVUS if you want,
Okay.
or
I think we can do the pot
okay.
after IVUS, okay, and we decide about.
Okay, and we can check the pot result and save one step. 4 or put the B5, Borja.
I think it's 4. 4.
Can we have a NC balloon 4x8? Please. Is there any question from the audience? No. ¿Y 12? ¿Te valdría 12, no?
Yo creo que sí, ¿no?
Si hay 12, Pilar.
Mientras no nos pasemos de 20 bien.
Mejor 8 que 12, ¿eh? Pero bueno,
Sí,
a ver si
es más.
Okay. No, the other important part when you do a bifurcation like here is to put enough length in the proximal vessel to do the proper pot. Okay, that is at least the length of your shorter balloon. We are using a 4x8 balloon, and we have enough space there to do the pot. And the proximal lumen of the left main with IVUS was 3.9, the lumen. So we are using a 4 balloon, 3.86. No, si quieres la luz.
Bueno, ok, no, es ok. Thank you.
Venga. ¿Vamos a quitar esto?
Sí.
Espera, que no puedo. Ok. A lo mejor lo ves sin este embus, ¿no? Con cine en vacío.
Sí, aquí vamos. I think we inflate in the osteon low pressure, okay?
The ostium was
Yes,
3 point,
no, yes,
probably only the pot, no?
no problem, no problem. Inflate in the ostium only six, because
6.
okay.
It was a little bit under expanded in.
And now the real pot.
Okay, we are there.
Right?
We can, sin contraste.
No contraste.
We are there.
I think
Okay.
it's a good position. Okay.
Okay, let's
Then,
go.
12, no?
12. Okay.
Okay.
Down.
Down.
Okay.
Vale, toquecito.
Tres.
Tres.
No hay nada. Okay, I think it's okay. Let's check the circ. And I think if the circ is okay, we can retrieve the wire from the circ and use it to protect the diagonal. One controversial issue is if you need to do kissing balloon when you do a provisional stent technique in bifurcations, especially in the left main. We are not doing kissing if we see in general that the side branch, in this case the circ, is okay. And we think that after the pot, if the angiographic result is okay and the IVUS in the... I think it's okay. Let's do the other caudal projection, the right, to see the ostium of the circ.
Yeah.
There is also a funny small intermedius branch that is still alive after the stent. Probably here. Okay. Cine. Okay. What do you think?
A few years ago, always open the circumflex, but I think now the result is very good.
We agree.
Probably.
And we can focus on the we can do IVUS. That's our plan. IVUS, please check it, and we can interrogate also the result of the stent in the left main proximal LAD, and even the distal landing zone of the stent, and probably the need to treat the distal, the plaque near the diagonal. Okay. No question, Borja, from the audience? Another question could be if this patient could be referred to surgery after the primary PCI or not.
With me, please. With me.
Okay. We can talk later bit before. Okay, there.
Yeah.
Está live, sí. Okay, pull back. If you see the angio, we will show you later on the IVUS. Se es copia de vez en cuando para ver dónde estamos.
Sí, aunque las diagonales no marca.
Okay.
O sea, es la primera.
We are doing the pullback. Ahí está bastante enfermo. Es copia un segundo.
Y ahora vamos a por la segunda.
Vale, pero hemos visto una zona severa ahí. Y ahora viene la primera. Que no la vemos, probablemente la tapa el calcio, ¿no? Porque ahora viene.
Ahora viene. Esa es.
Wow,
Esa es.
bastante severa, ¿no?
Y ahora enseguida el stent. O sea, es distal la diagonal, ver lo que hay ahí. Ese es nuestro stent ahora.
This is the stent.
The position is good, ¿no?
The position is quite good in the distal part. The expansion is also very, very good. This is the circ. The ostium of the circ is open.
Yeah.
And the proximal part is well opposed.
Yes.
Perfect.
The pot is.
Okay, stop.
The pot works good.
Okay, Pilar, if we can move the screen like before, and Borja analyze the IVUS for us. Okay, this is the play. Stop un segundo, Borja. We can focus on the IVUS, please, with the screen. Let's wait a second to do the zoom only in the IVUS. If we can put it in a big screen without the hemodynamics and the angio probably.
I prefer
To do it by yourself. Cuidado, 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 Pilar, que te llevas la pantalla. Pilar, Pilar.
this part.
No, que esto. Cuidado. Okay.
One moment, please.
So you can see now the IVUS, and Guillermo is going to analyze it outside. You can see now the pullback. This is the mid LAD. Distal. This is the diagonal.
Yes, this is the first diagonal.
This is the diagonal. So you can see the plaque there. Probably it's the same plaque than before, but now after the 3.5 stent in the proximal LAD, the plaque seems to be worse. Down in the middle. So 3.2.
Yeah.
Probably is another reason to treat it, no?
Yeah. Probably we need protect the diagonal and implant stent.
And can you measure a healthy landing zone distal to this part? Probably between.
That's the problem. Which is the
there
the best part?
It's 2.5 probably.
Probably more or less here.
Yeah.
I think 2.75.
2.75 could work well. Okay. Okay, so probably we need to remove the wire from the circ to introduce it in the diagonal. It's not very calcified, this part, but probably we need to predilate a little bit, no, Guillermo?
I think
or direct stent.
No,
direct stent.
Yes, no problem.
At 2.75, a synergy 2.75, and probably with the putting together the IVUS and the angio, the practical core registry, probably a short stent could be enough. What do you think? In the IVUS you have 15. Probably is that, yes. No? For near 15.
More or less, yes.
Okay, we can put the screens again than before, similar than before, and we will need a synergy stent 2.75 near 16.
No, or even 3, no? Because the previous stent was 35.
I don't know if we can do later on pot, because the distal part is so diseased that if we over expand the stent, probably we will have problems distally, no?
Okay. Okay.
So 2.75 by 15, 18, 16 is pairs. Yeah.
16 is synergy, no?
16. If not, we can go. No, synergy. It needs to be synergy. We are searching in the other side to find the perfect stent.
Y tres,
3 by 16. We can go with the wire to the diagonal in the meantime. Yeah. Okay, everything is searching in the other CAD lab for the 2.75, and if not, we can go for the perfect. Okay.
No.
The circle is open for sure.
Can I have the rotor, please?
The torque. ¿Lo tienes en la otra, ok? Sí, yo creo que sí, ¿no? Mejor. It's better. We have two synergy stands that can be used. One, you're there. Okay, perfect.
The advantage of the Sion Blue is maintain the curve.
Okay. I think just is enough. Okay. The thing, Guillermo, is 3 by 16
Yeah.
or 2.7 by 20. Let's put the cranial view. That probably is the best one to decide. Wait, sorry. I would go for the 2.75 20 or
I think yes, it's
2.75 20.
yes, no problem with this. Yes, I think the before the dust is the septal, no, the
Yeah.
three septal more or
Yeah.
less before.
Yeah, it's difficult to find in the angio and also in the IVUS the best position between the both diagonals because all the vessel is diseased. I think we can go overlapping the stents and then post-dilating the proximal part of this one. And let's see. Okay. We do apologize for the problems with the IVUS because it's a very interesting case showing the IVUS chip study. But I think we are showing you the best we can. All the images. Suelto.
Thank you.
Okay, let's go with the stent. As Guillermo said, we haven't seen any severely calcified plaque. We are going with a direct stent. Okay.
No
No
contrast,
contrast.
please. This is inside the previous stent. No?
Be careful because the dot, the radiopaque dot, is not the stent. You are just in the edge.
We can do a stent boost.
Okay, let's see with the wire. Escopia, por favor, que te centro un poco esta, a ver si se ve mejor. A ver, escopia. ¿Por qué no se pone más grande? Let's see if we can see it. Okay, let's do a stem boost. ¿Nos ponéis stem boost arriba?
Espera, que eso lo hacemos nosotros.
No, perdón, nosotros. This is the point. I don't know if you are seeing the stem boost, probably not, but the stent is a very important thing in every stent, and also in this one. The proximal radiopaque marker is not the proximal edge of the stent.
Now I think it's good.
Guillermo has retrieved a little bit the stent, and we are doing another stent boost. I think you are in the perfect position now. It's perfect now. Okay. Let's show it with the angio. Escopia, por favor. Un poco más grande, ¿no? Ahí, ¿no? Ahí. So I'm going to do cine o test?
Test. Yo creo que es mejor ya no moverlo. Ahí está bien.
We are there. Okay, let's go.
Yes. 12, please, because 12 is...
Nominal is 11, 12, more or less, yeah? 6, 12. The expansion is quite good, probably a little bit underexpanded at one point.
Okay, but
down.
I'm going back with the balloon and we can
overdilate a little bit. Inside the stent. Okay, there. Okay?
Okay.
Let's go there.
18.
18. 18. Okay. Expansion is quite good.
Okay.
Go down. Okay. So we need to do a pot.
Test, please.
Test. Okay, much better. Pot with 3.25.
Vamos a hacer un cine, okay? Cine, please.
No, I think the distal edge is perfect because the disease is there, but
probably the diagonal is the flu is good, but probably is in jail, no?
Mm-hmm. We can do the pot firstly and then recross.
Yep.
Let's treat the which balloon
or
nothing.
Is the fluid is good?
Okay, we can decide. So for the pot, 325, 3.
Yeah, 3.
NC balloon 3 by 8, 12. Any questions, Borjano? Perfect. 3 by 8. So this is another debate. This is we can look at it after the pot in another projection to see the ostium of the diagonal. And this is another question. If you have a good flow but a pinching in the ostium, we will need to decide.
Can I see the
12.
No, but
I have the wire. I don't know if we have more time, 10 minutes more to finish the case, or okay, we have 5 minutes more. We are in the pot and then decide. La guía se está retirando un poco, ¿no? Probablemente.
Ya, bueno, está marcando, vamos a dejarla estar.
Okay.
Only six.
There, distal to the.
Yes. Only 6. This is the. Okay. Now the real pot.
$18, ¿vale?
Okay.
Down.
18.
He subido 18, ¿eh?
Toque un poquito.
This.
The LED is perfect. Now.
Let's check the diagonal. Okay. I think we can do a couple of projections to show the final result from now, and then cut the connection and finish the case with the IVUS and thinking about the diagonal. Okay. ¿Tiene? The flow is perfect in the diagonal. Let's do another projection probably. ¿O de cráneo?
Okay.
No sé si le dio la cabeza al señor. There. Copia, please. This one? Okay. Yeah. So this is the point.
Yeah, it's,
What do you think?
But the fluid is perfect, no? I think we can leave without treat the diagonal, no? Because it's the flow is very good.
You decide. Probably another option is to try to recross with a wire and then do another without the jailed wire, or leave it like that. The LED is almost perfect. We can do another IVUS if you want to check the result. Okay, we have to retrieve the diagonal. Yeah.
I think the result is
yes, also because the diagonal is quite diseased. The flow is good. The image is similar than before. And if you dilate, probably you're going to dissect. And you are finishing the case with 2 stents, that probably is worse for the patient. Okay, I think we are done. Or you can do, you want to do another?
Beer.
We need to do another IVUS at the end.
It's mandatory the deluxe IVUS for the IVUS cheat.
Yeah, we are doing another IVUS just to finish the case. We have 3 minutes probably just to do the IVUS in the LED and finish the case. Ok, vente conmigo. Cuidado que está enredado. Probably we can move the screen again, Pilar, to show the final IVUS because we can advance it. No, now, because probably Guillermo can see the IVUS perfectly.
No, we're going to check the stents because the
Okay.
rest of the LED.
A little bit more, a little bit more, a little bit. 5 millimeters. Okay, there. Okay, let's focus on the IVUS with a big screen, please. Just a second. Just to focus on the IVUS in only one screen. And if we are ready.
Estamos terminando, ¿vale?
Okay, I'm going to start the pullback now. We are distal to the second stem. The position is perfect, the expansion as well. Probably could be a more proximal side of slight under expansion, but the areas are perfect till now. This is the one branch. The stem looks quite good.
It's a circle, no?
Yeah, no, it's perfect.
That's the diagonal?
This is the proximal, this is the circle.
Yes.
And this is the first stem. I think the result is quite good. Let's see okay, this is the left main. Okay. So we are finished. Thank you for being with us. We do apologize for the technical problems, and we see you in the second case in a moment. Bye-bye. Thank you.
Bye, thank you.